Charlie Gard, an infant with a rare mitochondrial DNA depletion syndrome, which left him blind, deaf, needing mechanical ventilation. He had progressive muscle weakness and brain damage. Charlie's fate was the subject of a prolonged legal battle that made worldwide headlines. Charlie was described as perfectly healthy at birth and was only admitted to the hospital at 8 weeks as his condition progressively deteriorated. The parents, they wanted to transfer Charlie to the US for a nucleoside bypass therapy, and that's when the case became world famous, with the Pope and the US President intervening, causing a frenzy on social media. A GoFundMe page was started, raising over £1 million for Charlie to go to get that treatment. His parents, Chris Gard and Connie Yates, fought to transfer him from the London hospital where he was on life support. The hospital, though, they wanted to remove life support because in their clinical judgment the prognosis was not too good, and they didn't want to take part in making the infant suffer further. The case went to the British High Court and the European Court of Human Rights, which supported the request to withdraw treatment. After several months passed and Charlie's condition got worse, experts advised that the treatment would be futile. And that's when the parents abandoned their legal battle, saying that it was too late to save him, and he was transferred to hospice where he later died. Now, the most common justification cited for supporting a Death with Dignity Act have been the principles of autonomy and dignity. It is very perplexing for most Americans to understand why a legal body can decide to withdraw life-sustaining treatment from a patient. But the laws in the UK allowed for the assignment of independent legal counsel for children to advocate for their interest rather than the interest of their families. The UK allows for court-appointed guardian for minors through the Children's Act of 1989. In the US, however, we follow a decision-maker model where a child is under guardianship and the caregiver, the parents, makes decisions on their behalf once they're deemed competent to do so. On the principle of beneficence and non-maleficence, physicians, doctors, nurses, we're sworn to do good, right? They should not offer therapies that are unlikely to benefit patients and that are likely to cause significant harm. Although the treatment has worked for some children, Charlie's condition was far too advanced to guarantee any success. The doctors offering the treatment, along with a group of experts, evaluated that the treatment would not be beneficial to Charlie given the severity of his illness. Now, the ANA Code of Ethics highlights that ethics in the nursing profession is very important because it forms a theoretical framework upon which we guide our decision making. We are able to make decisions that uphold the values of humanity as we practice with integrity, competence, and a sense of duty. Within this code of ethics, Provision 1 speaks to the compassion and respect for each individual's dignity and worth. Provision 2 speaks to the primary commitment to the patient, whether individual, family, group, community, or population. Provision 5 also states that the nurse owes the same duty to self as to others, including the responsibility to promote health and safety, to preserve wholeness of character and integrity, and to maintain competence and continue personal and professional growth. The highlights of these end-of-life ethics have been brought to the public through many controversial cases. One in particular is the Karen and Quinlan case in the 1970s, and also the Terry Schiavo case in the 90s. In both cases, the patients were considered by all professional accounts to have irreversible brain damage and in persistent vegetative states. This meant that their chances of recovery were very minuscule. But officials needed a law, such as the Death with Dignity, to withdraw life-saving treatment. The result was a number of legal battles surrounding the question of who decides what happens when the patient loses their autonomy by virtue of incapacitation. This is a fundamental ethics question which is often solved by advanced directives. Interestingly, though, in the Karen and Quinlan case, it was the hospital that wanted to withdraw life-saving treatment, and the family fought against this in the courts. In the Terry Schiavo case, however, it was the family. who wanted her husband in particular, who wanted her to die with dignity, while her parents thought she had a right to keep on living. The rationale in both sets of cases range from religious convictions to moral obligations to utilitarian values. Of course, those were adults, unlike the Charlie Gard case, who was an infant. As a practicing nurse, I have strict adherence to the ANA Code of Ethics, and of such I would approach this case from a position of advocacy. I think the courts took a utilitarian approach without necessarily empathizing with Charlie's parents. Nursing, however, take the entire family into consideration, and in the U.S., at least, the decision making would not be left to the courts, provided the parents are competent to make decisions on the child's behalf. At the same time, the proposed treatment was experimental and was not fully tested in animal studies or clinical trials. This, of course, raises an even bigger dilemma. We remember the Nuremberg codes for protection of human subjects in biomedical research. That voluntary consent is essential. The results of any experiment must be for the greater good of society. Human experiments should be based on previous animal experimentation, and also that experiments should be conducted by avoiding physical and mental suffering and injury. In our duty to advocate, we are also rooted in the principle of non-maleficence, which is doing no harm. Therefore, we could not also support an unproven treatment unless there is broad consensus on its potential to heal and not make Charlie's suffering worse. In rare cases where patients do not have advanced directives or someone to make decisions on their behalf, professional representation can be applied, where, for example, two physicians can sign off on a treatment plan or do not resuscitate or intubate orders. On the ethics of justice, we have to ask a few fundamental questions. Should the courts decide on behalf of the child? Should the child be prohibited from traveling overseas to get treatment? With the 1.2 million pounds that was raised on GoFundMe to send him to the US for treatment, did he get a fair shot? Was there legal precedence for this decision by the UK or the European courts, for that matter? What role did the system of paternalism play in this case? Does it violate the patient-centric model of healthcare that we aspire to? When healthcare cases create an ethical dilemma, there are many resources to help resolve issues of disagreement. Local ethics community as well as regional healthcare ethics networks are a common phenomenon as cases continue to grow. The COVID-19 pandemic, for example, is a stark reminder of the importance of ethics in healthcare. Many people died, and many families were left devastated because the conversations about death and dying were postponed. In situations where a local ethics committee is not able to make a clear decision, an ethics consult could help by providing guidance on how to proceed. The Center for Practical Bioethics recommends using a TPOP, or a transportable physician order for patient preference, or a POST. The TPOP aims to improve the communication of a person's preference regarding life-sustaining treatment and thereby generate high-quality medical care. The Charlie Gard case is a good reminder that we need to continue these conversations and take a long, hard look at the way we did things in the past and ask the tough questions that I mentioned earlier. As we continue to innovate and advance science and healthcare, we need a strong ethical foundation to ensure that human dignity is preserved. And I'll conclude with the Institute of Medicine's core competencies for health professionals. The core competencies include providing patient-centered care, to work in interdisciplinary teams, to employ evidence-based practice, apply quality improvement, and to utilize informatics.